It is my privilege this morning to introduce our first speaker. Dr. Sarah Y. Vinson is a physician who specializes in adult, child, and adolescent and forensic psychiatry. She's the founder of the Lorio Psych Group, an Atlanta, Georgia-based mental health practice providing expert care and consultation. Dr. Vinson is also the founder of Lorio Forensics, which provides consultation in a wide variety of criminal, civil, and family court cases. Dr. Vinson is also an associate clinical professor of psychiatry and pediatrics at Morehouse School of Medicine. Just 2 years after joining the faculty, she was honored as Faculty of the Year in 2015. Please join me in welcoming Dr. Sarah Y. Vinson.
Good morning, everyone. So I'm glad to be here this morning, and just to give you a bit of context, my perspective and my lens is very much so informed by being the daughter of a police officer and probation officer, but also being a clinician who has worked in public sector psychiatry, be that in juvenile justice, jails, public sector county clinics throughout my career. And so our agenda this morning, there we go, is that we'll review social injustice and mental health, child trauma and institutional neglect, structural and race-based trauma, what the record reflects or not, and trauma-informed service. And of course, this is not a lot of time to go through these topics. This will be more introductory for you. And my goal with these talks is not that you take away a bunch of facts that you have memorized. It's not about changing what you think. The goal is to change how you think and to help you hopefully start to challenge some of the lenses and default ways of thinking that don't serve our clients well. So first we'll start with what is trauma. It's a word that has been used a lot lately, and I think it's a helpful place to start. So in broad strokes, when a mental health professional is talking about trauma, it's some experience that has stayed with the person, that has continued to affect the person, and that could be something that's a physical trauma that leaves physical scars and changes in how the body functions, but it can also be mental or emotional function that leaves some sort of cognitive or emotional scar or impact or thing that stays with that person and changes how they function long term, even after the traumatic event has been taken away. And so when we consider trauma, as we consider most things in society, I would actually say all things in society, we have to be mindful of societal inequities, and we have to be mindful of whose experiences are centered. And the same is true when it comes to trauma and when it comes to diagnoses in the mental health care system. And so when we have common discussions about trauma, when we use instruments like the ACE questionnaires, there are ways that that centering of certain experiences and the marginalization of others plays into things being recognized or not, things being overlooked or not, things being accounted for or not. So just to give you all an example, many of you are probably familiar with the 10-question ACE questionnaire. That original questionnaire was normed on a population of largely white, largely college-educated, largely middle-class people in Northern California. It's not quite representative of the people who end up justice involved, and yet we've seen that applied to that population quite frequently. So context matters. When you're talking about mental health, when you're talking about trauma, where is really important. It's not just who or the individual or its symptoms you can diagnose in a person, but the environment around that person is really very critical. So I realize I'm in ACC country here, but I'm a University of Florida graduate. Go Gators. All right, we got a Gator in the room. You know, we really care about college football down in the Southeast. I'm a Florida native. And this is a picture from an LSU football game, right? there are things that people do at college sporting events, especially in the Southeast, that they would not do in other places, right? No matter how excited you get about what I say, no matter how much you don't like what I say, you're not going to stand up and clap or boo me at any point during this talk, right? And it's not that you're not capable of standing up and clapping or booing people. It's just that this is not the place where we do it, right? We're all social creatures, and what we do, how we express ourselves, is shaped by the environment we're in and the social norms that are set in those environments. Context also matters in perspective. So you can look at the same thing and see very different things from different vantage points. And that's really important to keep in mind because the vantage point that we have as professionals or as people with titles or as people in a position to make decisions about people are very different than the vantage points that the people have who are going through the system. We also know that context matters in opportunity, right? So there's a narrative sometimes that America is this land of equal opportunity, and I would simply counter that by saying, where did you, or how did you decide where you were going to live and raise your kids? And for most people, that question is answered by the school systems and the school district because we all know that opportunity is not equally distributed. And so as we're going through this discussion of trauma, and really as you're thinking about mental health or mental illness or plans and discharge planning for the people that you work with, it's really critical that you mind the gap. So if you've ever been to London, they have this subway and they say repeatedly, mind the gap, mind the gap, mind the gap. It's a whole thing. They even have like t-shirts and stuff. But the reason it's so repetitive, right, is that the consequences of getting it wrong are dire. And there's a way that we have to be repetitive and mindful and always keep it front and center that there is a real gap between our lived experience and the lived experience of the people that we're trying to understand and make plans for. And so this takes us into social injustice and mental health. So as I mentioned, throughout my career, I've done public sector work. I've also had some private patients and done forensic consultation. And these are three young men who I met in these different settings. So one was an adult defendant in a capital murder case who said, I was proud to make it to 21, even though I was in prison. The second was a software programmer in my private practice clinic who, when I asked him about his childhood, said, school was all I ever really had to worry about. And the third was a detained teenager who said, they say I'm supposed to care about people when ain't nobody cared for me. Often when we say mental illness or when we say mental health or the mental health treatment system or the mental health care system, we're using the word health, but we really have a sick care system, right? People don't enter the system to promote health. They only go there when there's a problem. And even when we're talking about the mental health of people, we often frame it in terms of diagnoses or symptoms or medication compliance. But there's this definition of mental health from the World Health Organization that I think is helpful, right? Because the goal is not just that people aren't ill, is that they're healthy. And sometimes, and medicine is very guilty of this, the focus is on pathology. So the World Health Organization defines mental health as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to her or his community. Notice how much of that definition is dependent on opportunity, on what's happening around that person, on social networks. It's not just about, Mr. Johnson, are you adherent with your medication and seeing your case manager? Right? There are all these elements to it that depend on societal networks and structures being in place. So the idea of social justice is one of assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. There's been a lot of discussion about the fact that people with mental illness are overrepresented in the criminal justice system. But if you take a step back and take a bit of a broader view, what you find is that people who are marginalized are overrepresented in the criminal justice system, whether that is people who are marginalized because of race or class or learning disabilities or something stigmatizing like mental illness diagnoses. So when we think about racism, sometimes the picture that comes to mind is someone who has hatred in their heart and is trying to harm somebody, who is actively trying to suppress another individual. But when we're considering it in the structural context, it's really about outcomes, right? So when you have policies and ideas that produce and normalize racial inequities. And the point here is that no one has to try to do it, but if you're seeing that there are racial inequities in your system, that should raise red flags. And then with health inequities, disparities in health that are a result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. And I'm sure you've heard the word health disparities before, but the distinction with inequities is that you're acknowledging that there are these structural drivers for the differences that you are seeing. I'm sure you've heard the word trauma. Maybe you haven't heard the term structural trauma, but I would posit that it's probably the most persistent form of trauma in many of your patients' lives. And this is when systems, structures, as they're configured and routinely operate, actually act as sources of harm. So I can give you a quick example. My clinic on the west side of Atlanta, that's the county clinic, seeing kids on Medicaid and who are uninsured. They all are routed to these grossly underfunded school districts, right? So in those school districts, it takes us 2 years maybe to get a psychological evaluation. And in the meantime, while kids have learning issues that aren't being addressed, they get frustrated in school, they act out, they're labeled as oppositional, right? And a place that you tell them is a place they go to get an education so that they can better themselves in life becomes a place where they're scapegoated, where they're ostracized, where they don't feel like they belong. And if you're a poor child of color, if you don't end up there, we all know where people are more likely to be. And so as we're considering mental health and mental illness, as we're thinking about trauma and people's response to it, it's really useful to get out of this way of thinking of people are either mentally ill or they're not. They have a diagnosis or they don't, because that's not how people work. We are all on a continuum between mental health and mental illness. We are all people who may go up or down on that continuum depending on what's happening in our lives. And I think that we saw in these past few years with the collective trauma of COVID and all of the repercussions of it, how a population-level stressor resulted in changes in mental health diagnoses across the board, even in people who have traditionally been quite resilient, like medical professionals. And so as you're considering people who are coming through the court, it's important to consider their risk factors and the things that they're doing that are coping maladaptively. So a prime example of that would be substance use, right? But in seeing them as a whole person and in trying to set them up to be mentally healthy, it's equally as important to consider protective factors, thinking about adaptive coping, and supports for them, right? We can't just tell somebody stop smoking marijuana if we don't understand their marijuana is helping them self-treat their voices. You gotta give them something else for their voices if you want them to stop smoking marijuana. And so when we, there we go. So there are healthcare system inequities as well. What we see is that medicine is a business. I wish I could tell you it was this great altruistic system. It is not. People in the system may have that motivation, but we're constrained by the limits of where we work. And health insurance coverage is a big mediator of what care people get. Medicaid rates are a big mediator of availability of care, and we see that in the healthcare system. The inequities are just as pronounced, if not even more so, as they are in other systems like the criminal justice system. I do a lot of talks with attorneys and judges, and sometimes it seems as if the idea is, well, if I can get them into the mental health care system, then we've done our part and they'll be taken care of. I wish that were true. But the same issues that are present in terms of marginalization and differential treatment are present in the healthcare system as well. So by way of example, in 2018, when you look at people's access to care, and I'm gonna use Black and Latinx folks, and again, I welcome you to think about marginalized populations more generally, but we'll use the data for these two groups. In 2018, 69% of Black adults with any mental illness received no treatment, and 42% of Black adults with serious mental illness received no treatment. When you look at Latinx adults, those numbers are 67% and 44%. So I'm pointing this out to you because sometimes there's this idea that if people don't have a diagnosis or they don't have a treatment history, that means that there's not an issue. Because for most of us, when we have been sick, we can go to a doctor, we can get diagnosis, we can get treatment. That's not the same for the population that's overrepresented in the criminal justice system. So no diagnosis does not mean there's no issue, because a diagnosis requires access to a system and for someone to diagnose you. So sometimes no diagnosis is really an indicator of that person's access and the adequacy of services in their area and tells you less about the individual. Now, often in conversations, particularly as it pertains to Black and Latinx people, when you give people numbers like this, they're like, oh, well, the stigma in those communities is so high, and that's a big problem. Well, when you actually ask Black people why they don't get mental health care, what they tell you is that cost is the #1 reason, and this is twice as often as minimization of symptoms, and nearly 5 times as often as stigma. So it doesn't mean stigma is not an issue, but it means that scapegoating stigma causes you not to appreciate the real driver, and means that if you're trying to fashion a solution, you're going to have the wrong solution. Because if the problem is stigma, I need to educate the client and tell them. If the problem is cost, we need to put our heads together and think about how we work with the systems in the area to make services more available to people. And we see that this is amplified when it comes to substance use disorders, where the numbers of people who get access to care are even worse. So when we think about those numbers being worse and this interplay of what's happening in society and what people present with, a prime example is there were different responses to the same disorder, right? So opioid use disorder, cocaine use disorder by the DSM are the same illness. How they've been treated differently, not just in the narrative, but in the allocation of resources. Research dollars, training dollars, clinical support dollars that have been specifically targeted and earmarked for the disorder that affects the population that is seen as salvageable or worthy of care or more sympathetic, right? And this also contributes to treatment disparities. So next we'll go to child trauma and neglect. So we know that early impressions matter, and it's not that once you're an adult, you're fully cooked and nothing can harm you, but when you're early in life, your brain is it has a characteristic that we in medicine call increased neuroplasticity. And that's just a word for saying it's more like wet concrete. What happens there can shape it more easily than things that happen later in your life. So I grew up in a small town called Pace, Florida. Anybody ever heard of it? Oh my goodness, we have one. That almost never happens. So Pace, Florida, I tell people it's functionally Alabama. It's Central Time Zone. We literally ran around cotton fields for cross-country practice when I was in high school. And when we moved there was a Hardee's, a Piggly Wiggly, and a flashing yellow light. And in Pace, Pensacola was the only big city near us, if you can call Pensacola a big city. And out of the big news outlets, ABC, NBC, CBS, ABC was the only one that played Pensacola news because the other ones played news from Mobile, Alabama. So I grew up watching ABC, right? I grew up watching Good Morning America. I grew up watching World News Tonight. And to this day, if I have the opportunity to watch a morning show, guess which one I'm watching? Good Morning America and George Stephanopoulos, because these it imprinted early on in life. I could be missing really quality morning programming on CBS for all I know, but I won't, right? Because I'm doing what is familiar, and that is something that we all do as human beings in ways that have minimal implications, like morning programming, but in ways that have bigger implications too. So looking into development, and as mentioned, I'm a child psychiatrist, and even with adult evaluations, that lens is very helpful. So if a fire alarm went off in this room right now, my guess is most of you would not run out of here full speed, right? Most of you would look around, see if anybody else is running, see if there's smoke, see if there's other alarms going off. You would take the alarm as a sign that you need to pay attention. You wouldn't necessarily react to it right away, right? And that's because your experience of fire alarms is that the signal or the alert has not been consistently paired with an actual threat. So as we go through life, our anxiety, our fear, if we grow up in a safe, secure environment, often is not paired with an actual threat. If you grow up in an unsafe environment where you're constantly traumatized and that alarm or that signal of feeling anxious or fearful is consistently paired with a threat, or paired with a threat consistently enough, you don't have that same luxury of taking in more information and deciding what you're going to do. You react right away because in your early life, reacting right away might have been the difference between life and death. So that's one kind of trauma, right? Those traumas that are more acute and that place people at risk. But there's another kind of trauma we don't talk about nearly as much, and it's one that gets into this topic of institutional neglect and child poverty. So in Kentucky, 1 out of 5 children live in poverty. And just to give you some context, that is less than $26,000 for a family of 4. So you can imagine there are a lot of places in the state where $26,000 isn't going to necessarily be enough to consistently meet a family's needs. Nearly half of Kentucky's children are living in households with annual income below 200% of the federal poverty line. And for Black children in Fayette and Jefferson counties and Latinx children in Fayette, the rate is 2 out of 5. So why am I bringing this up in a child or in a trauma lecture? So we know that there are things that are adverse childhood experiences, but on the flip side, there are positive childhood experiences. And the positive childhood experiences, things like having a home, an invested caregiver who's able to be present in educational needs, are mediated by money and socioeconomic status. And poverty undermines those things that we know put people on the right track. Now, that's not to say that if you grow up with poverty, you're going to have the chance of being mentally healthy, but we do know that it is a risk factor, and not only is it in itself a risk factor, but it impacts a lot of other risk factors that are well documented as well. So going back to this person I evaluated, and I did change his name for the sake of the evaluation, he said, I was proud to make it to 21 even though I was in prison. He'd been incarcerated from the age of 17 to 21. His incarceration was for a nonviolent offense, and so was his violation. So often when we think about people's unmet needs, we think about them as risk factors for mental illness, but that same list are risk factors for DJJ involvement. And so when we think about or look at Miguel's environment, he certainly had the things that we're used to seeing, right? So family dysfunction, intergenerational transmission of trauma, abuse in the family, violence in the neighborhood. But how is it that was allowed to happen, right? We know that these things are harmful. It is well documented in the medical and the psychological and the mental health literature. At this point, we are continuing to allow people to be exposed to things that we know are going to set them up to have mental health issues or be at greater risk of it. Well, that was allowed to happen, that was enabled to happen by a multi-system failure, right? So he was in 12 different foster care placements throughout his adolescence. Even though learning disabilities had been diagnosed early in his life, as you can imagine, with 12 different placements, those were not appropriately or consistently addressed. And in the state, right, you had low mental health spending, CPS, or Child Protective Services understaffing, and there was a time when there was a very punitive stance toward adolescents. So rather than looking at him through a lens that considered his development, that considered the institutional neglect that he had experienced, they just looked at the fact that he happened to have marijuana on him. And so when we think about problem youth, the same risk factors overlap for mental health issues and for justice involvement. And what you find is that things that are adaptive responses when they're under threat become pathological responses when not. But because of that wet concrete in their brain, it's harder for them to see the world a different way. When we look at trauma and justice-involved youth, and in an ideal world, the justice system for kids would end up diverting people from the adult system, but we know that that's often not necessarily the case. Trauma is the rule rather than the exception. So 90% experience at least one, 84% more than one, and 75% have experienced traumatic victimization. And this is data that is drawing from measures like that ACE questionnaire I told you about earlier that don't account for things like neighborhood violence or race-based trauma or things like that that are going to be more relevant for this population. So if we're just going to take a diagnosis of oppositional defiant disorder, for example, here, because it ends up being a kind of pipeline diagnosis for oppositional defiant, then conduct disorder, then antisocial personality disorder. And there's a way that that marginalization of certain groups and the centering of certain people's perspectives applies to children and adolescents as well. So with ODD, the diagnosis is a pattern of angry, irritable mood or argumentative defiant behavior. And there's no prompt, right? Asking people to diagnose this to get them to consider, does the child have things to be angry about? Or have the adults and systems in their lives been consistent and helpful? And most of the time, for the folks we're dealing with, that has not been the case. Angry, irritable mood is something that's a highly nonspecific symptom, and the population that's overrepresented in the criminal justice system is more likely to have intellectual disabilities, more likely to have environmental neurotoxic exposures, more likely to have trauma, and so there are all kinds of other explanations for that symptom than ODD. And then argumentative or defiant behavior. So embedded in that criteria is the assumption that the adults in their life have exercised good judgment and acted in their best interest. And that almost always, at least for the cases I'm asked to evaluate, have not been the case. And so what we see with oppositional defiant disorder is that the child, the member of the disadvantaged group, is given the diagnostic label, while the behavior of the advantaged group, the adult, is presumed to be right. And we see this not just as it pertains to youth, but as it pertains to people in marginalized communities, people who are in racially minoritized communities, where that vantage point of the diagnoser ends up over-pathologizing the person because they're failing to take those things into context. So any child's behavior takes place in the context of family, and any person's behavior takes place in the context of the larger society. So coming back to this poverty issue, right? It's not a coincidence. 80% of DJJ-involved youth have families on public assistance or incomes under $30,000 per year. Anybody care to solve this? But you must. I'm asking you to solve this. I don't see anybody like scribbling on paper or... So, I mean, if you could solve it, maybe you would, right? But you don't know how, right? And sometimes people ask us to do things that we don't know how to do. And as adults, we can explain that, we can articulate it. Often we're not at a level where there's a power differential where we can't speak up about it. When you have kids in school districts that don't properly test them, and that don't know what they can do and not do, and that have them sitting in class with undiagnosed learning disabilities, they're asking kids to do the equivalent of that all the time, right? And they have to go there, they don't have the words, they're at a power differential, and so the way that they express their frustration, right, can be misinterpreted, and often is. And so, again, we talk about mental illness, we talk about trauma, we don't talk about learning issues as much, but that is also a group that is grossly overrepresented in the criminal justice system. There's an attorney, some of you may know if you're in the juvenile justice space, named Randy Waldman. She's at Emory Law School. She's been a frequent collaborator for years. And one of the things that's really interesting is that she's the attorney in the juvenile defender clinic, but for her clients, she spends just as much, if not more time in the schools as she does in the juvenile justice system. Because what she finds to a T is that they have undiagnosed, unaddressed mental health issues that are driving their disengagement and a lot of their problem behaviors in school. So there are all kinds of disability or ripple effects from learning disabilities, right? So this can happen in school, this can occur in court, right? A child may seem like they are recalcitrant or unwilling to cooperate or being oppositional with you, and it could be they just don't understand what's happening, and it could be that they are being misunderstood. And so what we have, right, is a situation where youth with mental illness are overrepresented in the justice system. And this takes us to structural trauma. So again, this is the idea that sometimes the way that we work as a society looks less like the dream that some of us may have experienced in this country than we would like. And by and large, the people who become members of the professional class either grew up in the professional class, or they're people for whom the system worked, right? Like they were able to go through school and progress and have a different experience of life. But that is far from the universal experience of this country. So there's a Harvard economist who says your chance of achieving the American dream is nearly twice as high in Canada relative to the United States. And that's because of the reality of what upward mobility looks like in this country. And we're seeing ways that that is actually becoming even more pronounced. And so the impact of that, right, is that when you have issues that are this big, that are unrelenting, that are inescapable because they're these systems issues, is that there's a demoralization that can happen, there's a resignation that can happen, there's an acceptance that can happen of where you are in society or what you may have to contend with. And so when we're considering people, those characteristics and narratives of the larger society, so for example, those ideas about who is worthy of care or treatment or compassion, depending on which substance you use or what neighborhood you live on, are going to impact not only how people feel, but also their experiences with treatment. And next, I will come to race-based trauma. So Frantz Fanon was a psychiatrist and psychoanalyst, and he said, once and for all, I will state this principle: a given society is racist or it is not. Often when you have discussions about this, people say, well, we've made progress, and in some ways we have, but it doesn't mean that that progress negates the reality of ongoing racial inequities in society everywhere that people take the time or care to look. And there's a quality about race-based trauma that is remarkable in its ubiquity, right? So I'm someone who went to school and trained at Harvard and had 3 board certifications, and really, after all that, ended up leaving my first job because of racism. You can never out-earn or out-educate it. You can never get away from it. And there are manifestations of it that follow you in a society and that you really can't do anything about. It is a constant weight that people carry, and one that is not captured by things like diagnostic criteria or DSM. In Atlanta, I take care of mostly Black patients, whether that's in the private practice or in the public clinic. And I can tell you that in the private practice, the manifestations of racism are more interpersonal, right, because they're in more mixed communities. Whereas in my public sector clinic, Atlanta remains very segregated as a result of redlining and all kinds of intergenerational transmissions of wealth and not wealth, that there's very little interaction with people who aren't Black. But their experience of race-based trauma is in the dilapidated schools they're going to that are leaking from the ceiling while they're trying to learn, right? So there's a way that you have to acknowledge this, that you have to think about it and be mindful of it, because sometimes when people come into your system, even if you're trying to be helpful to them, what they may carry with them is an experience-based distrust of systems' willingness and ability to actually act in their best interest, because often they have not. And so what we see is that there are also reliably racist outcomes in the criminal justice system. So there was a survey done, I think it was in 2019 or 2020, where most judges acknowledged the system had issues with race. We know that the match of who is making the decisions versus who the decisions are made about by race is quite disparate. And in medicine, we do this thing when we're trying to understand relationships is look at a dose response of 2 things. So do they just kind of run together, or does one cause it? So back when people weren't sure if cigarettes caused cancer, one of the questions they asked is, well, if you smoke 2 packs a day, does your risk of cancer actually go up? And that helps you understand that this is something that's actually causative, right? So a version of this is looking at shade, so how dark-skinned you are as a Black person. And what you find is that there are sentencing outcomes after you control by the crime and prior criminal justice history. There are sentencing outcomes that differ not only by race, but by shade as well. We also see that Blacks are less likely to be referred for mental health evaluations or to diversion programs. And I can tell you, just based on the stressors and the things that we've outlined, that it's not because they're a mentally healthier population that aren't in need of those services. And so next we'll go to what the record reflects or not. And so because of how these systems are configured, because of who is writing the criteria and interpreting the criteria, what you can see is that there's a failure of recognition of trauma's impact. You may have things like surface diagnoses and descriptions. So to go back to that ODD diagnosis or that conduct disorder diagnosis, those are diagnoses you can make based on the kid's disciplinary record at school. Whereas a PTSD diagnosis requires you to establish a rapport with that child and have them tell you, a stranger, about the most difficult things they've experienced in their lives, right? So it could be that it's really driven by trauma, but it's easier to ascertain the symptoms to check off the list for other things. And I see that all the time as a forensic evaluator looking back at people's childhood records. Mistrust of systems and difficulty with disclosure. They could have symptoms that are getting in the way, so these undiagnosed learning and speech issues, and then structural barriers to being able to access care. And there's influence potentially at every stage with bias in disciplinary procedures and evaluators and how clients may experience power differentials that in their lives, when those haven't gone well, they in and of themselves may be triggering. And what is often framed as poor engagement, right, or as people being oppositional or resistant, is that there's a lack of accessible community resources or demoralization, or there could be plans that have been made without taking into account kind of the realities of that person's situation. So if they are expected to report for probation every week, but they're in a county with no public transportation and their aunt is the only one who has a car and she works 9 to 5, it's going to be really hard for her to report. Not because she doesn't want to or she's trying to be oppositional, but practically it's a really difficult thing to do. And so what do we do about these things and some implications for trauma-informed service? And so just as I mentioned those adverse childhood experiences, we know there are positive childhood experiences as well. There's a psychiatrist by the name of Carl Bell who talked about how risk factors were not predictive factors because of protective factors, right? And so as we're thinking about the continuum, what can we do in society or with the people that we're working with to promote these positive childhood experiences? And it's not quite as simple as you have this many over here and you have this many over here, but we know that it mediates the effects of those adverse childhood experiences. So, being able to talk to their family about feelings, seeing their family as a source of support, feeling like their family looked out for each other and stood by each other during difficult times, feeling safe and protected by an adult in their home, and having someone to take them to the doctor if needed are all examples of positive childhood experiences. So if you're in a position to work with youth or to inform things around youth, these are all things that you want to try to preserve. And it may be that they don't have families that are capable of doing these things at this point, right? And then you think about interventions like family therapy to help facilitate that. There are community-based positive childhood experiences as well. So this is, they enjoy participating in community traditions, they feel a sense of belonging in high school, they feel supported by friends, and they have at least 2 non-parent adults who take genuine interest in them. And that community traditions part is really critical. We know that vacuums generally aren't good, right? And in the absence of things, bad things can grow if we're not intentional about what we cultivate. I have recently ended up on a lot of cases in New Orleans, actually, for adolescents being tried as adults. And it's a case study, really, in how a community's structure being undermined by a series of disruptions has really left this environment where the options for the youth that are adaptive, that promote good behaviors, have been taken away. And in the absence of those things, you've seen just a ballooning of issues with youth. It's not that all of a sudden all of these kids are bad people, right? It's that they have not had alternatives made available to them in an intentional way by the structures in that city or in that environment. Things like after-school programs and community centers and YMCAs and PE and sports, those things really do matter. And when we're talking about preventing involvement in the criminal justice system or accounting for trauma, it's these community-level interventions that are often overlooked, but are actually quite important. I do want to spend a little bit of time, not too long, but just on this idea of resilience. It is important to acknowledge. It is a critical consideration, something that we want to always know it is a possibility, right? That these kids in these communities and the adults that they grew up to be are not doomed. That said, people have their limits, right? And sometimes in the discussions of resilience, there's less discussion of why do we put so much burden on certain kids or certain communities to be resilient, and why can't we put as much emphasis on trying to protect and nurture and position them for success in the first place. And so when we think about that solid foundation, I welcome you to consider that there is mental health in all policies, right? So it's not about if a child has access to someone like me to prescribe them a medication. That's a very, very small piece of the puzzle. If we're talking about mental health promotion and addressing trauma and being trauma-informed, by the time they get to me, that's the medical equivalent of tertiary care. It's the medical equivalent of they've already had a heart attack and things are going really wrong, right? If we're thinking about how we consider trauma, how we divert people from juvenile or criminal justice system involvement, then that starts with their foundation and with what they have at home. A true home, so things like housing stability, food security, and having basic needs met. By way of example, in Atlanta, we are having a lot of folks move down to the city. All the folks moving down have a lot more money than the folks who are already there. And so in my clinic, where I have aunts and grandmas raising 2 or 3 kids, and the landlord's deciding not to renew their lease because they're building a bunch of townhouses there, that trumps what I can do with Prozac, right? And so housing policies are mental health policies. Food security, we don't often think of the brain as an organ, but it's an organ just like anything else is. It is developing and growing in kids, and in kids it's developing and growing at the most rapid pace it's ever going to develop and grow at any point in their lives. So to have policies that don't make sure that kids are fed and have food is a mental health risk factor on a population level. That is a choice. Do families have basic needs met? A reliable caregiver. So is there a consistent available adult? The adults in these children's lives have often dealt with the same stressors and risk factors, right? In my clinic, the county clinic, I teach young doctors, so residents and fellows. And again, you know, the people who end up in medicine, by and large, not always, but the people who have the privilege of becoming physicians usually come from somewhat supportive environments, right? So they come into this clinic, and this, you know, race is really removed as an issue there because we're all Black. It's a HBCU medical school. They come into clinic, and sometimes there can be this judgment of these parents and these mothers or these grandmothers or these aunts. And one of the conversations we have over and over again is that the parents can't give the child what they themselves do not have, right? So it's not enough to say we're going to get this child in therapy. We have to get the family in therapy, right? The primary caregiver needs to be able to have access to support and things of that nature too. Because who that child believes they are, the reflection that weighs on how they see themselves in the world is really based in that primary caregiver and what they're able to show them. And how they're able to advocate for the child, right? So it's not that every child in APS schools doesn't get what they need, but the ones who get what they need have parents who are extremely good and present and capable advocates. Educational opportunities, so things like safe schools, systems that prepare them for career or college or vocational school, and that have adequate special education resources, and then things like healthcare, so medical care, mental health adequacy, and access. We've seen some really interesting things in this country in the past, decade or so, as it relates to disinvestment in public education, and that absolutely has real consequences for the population that we're talking about. And so trauma-informed practice and policy. So number one is you take upstream action, right? Because by the time they have the break or they are addicted to meth or cocaine or opiates, you're going to have a lot of damage to undo. So those upstream interventions like providing opportunities in the community, doing things to support families are going to be really critical. Advocate for policies that address social and structural determinants of mental health. Communicate with elected officials and promote equitable representation, and form cross-sector collaborations and community coalitions. What it's going to take to do this better cannot be housed in any one system. And really, most of what it's going to take to do this better is not going to be in the mental health care system. It's in these other systems that impact these drivers and these mediators of mental well-being. Now, of course, once these issues arise, it is important that the mental health care system is equipped to handle it and to respond to them. But if we're thinking about this population as a whole, these other things have to be front and center. So as you're thinking about tweaks to the system or how you approach it, one of the things that I want to highlight is this idea of racism being something that is structurally mediated, right? So it's not that anyone is trying to have the system have different outcomes by race, but if it is, then that is there. I don't know of a system yet that can show that it doesn't have different outcomes by race, so you can assume that it's an issue in yours too. When we have reforms and we say, well, this is race neutral, there's no such thing. Because if you're putting a race-neutral reform on a system that already has problems as it pertains to racial inequities, the system you come up with is going to be a new version of a racist system. So as you're going through and considering changes and revisions, take it as an opportunity to do stratification by race of outcomes on the front end, and then do it by outcomes by race on the back end, and see if this is something that you can change and shape as well. And so this work really does require work internally in your professional settings or in alignment with your professional identity, but in the community as well. And so I would welcome you all to consider the power that you have. And sometimes when it comes to problems that are this big, it can feel like you don't have as much power, but if you're in this room, you have a considerable amount, and I would say in many ways, or in many respects, much more power than the people who are court system involved by and large. And so what is it that you have power over? So power over is when you can influence or coerce others. Power to is when you are able to change existing hierarchies. Power within is the collective power of communities or organizations. Power with is the collective power of communities or organizations. And power within, the individual capacity to exercise power. And it really is going to take a lot of people leveraging all of these different kinds of power in order to correct these issues, given how far off we are with marginalized groups of people being overrepresented in the justice system. So often in the court system, the conversation starts with diversion. But as a child psychiatrist, I would challenge you to start with direction and development, right? Because why is it that so many people are in need of diversion in the first place? And that's because of these issues that relate to direction and development. And so some practical implications of that. So as you're trying to be trauma-informed and understand people, understand how they got to you, but also understand how you may be able to support them in staying out of the court system or successfully re-entering society. These are some questions to consider. So where were they directed to early on? And what is the overall outcome desired now? What has supported or warped their healthy development? And what is needed to address the biopsychosocial impacts of those things that have supported or warped their healthy development? Have they had an assessment that includes a trauma history, including community and structural issues? And what basic resources do they and their family need? what have been their adverse childhood experiences, and what have been their positive childhood experiences, and what traumas are they continuing to contend with and face. So in looking at your staff, is staff aware of developmental and trauma issues pervasive in the population served? So it may be that the client is not super forthcoming about what their neighborhood was like growing up, but we all have the ability to look up data by zip codes, right, and to see what kind of things people were exposed to. We're able to look up school districts and see how college and career-ready people in their graduating class were when they went through that school system. Are accommodations being made for cognitive or communication difficulties? And if they're not, that's really critical, because that 33% number for learning disabilities I showed you is probably an underestimate. And there's going to be a lot of people with intellectual problems, with mental health problems, with learning issues that are going to impact how they can communicate or not. And so taking the time and being mindful of letting people articulate things in their own words, being cognizant of your word choice and sentence structures is going to be really, really critical. As you're considering where people go, what their disposition plan is, what reentry looks like, there are some things to keep in mind. And again, them going to counseling and therapy and getting their medications is cool, but these are the things that we know are going to help them have a better chance at succeeding. So preservation of positive relationships and identities. Are they able to continue to stay in touch with their family one way or another? It is disheartening when things like prohibitively high cost of phone calls make it hard for people to stay connected to their families when they're away, right? Because that connection to their family is a support network they're going to need in order to have a chance at successfully re-entering society. Consideration of educational needs and placement decisions. So to come back to that marijuana example, right? You can't just tell people stop smoking weed if you don't give them an alternative, right? If people don't have alternatives to feed themselves and their families when they get out, there's going to be less of a chance that they're going to be able to take another path. So thinking about that in terms of placement decisions, when it comes to coworkers, when it comes to clients, having them restate their needs, and pairing of communication methods with abilities. So which approach meets the person's needs, right? So thinking about the individual, while also accounting for the family system and the community. So I wish that I could tell you that when I'm practicing medicine, I'm able to give people what they want purely based on what they need and what their diagnosis is. I don't get to do that, right? Because the reality is what their insurance will cover or not, pay for or not, what the pharmacy has on stock in their neighborhood versus the other side of town, whether they have transportation or not, is going to dictate what is a reasonable plan, right? So in talking to the residents and the fellows I work with, one of the conversations we have is, what's the optimal treatment? Well, the optimal treatment is the treatment that the patient is able and willing to follow, right? And we have to have that same approach when it comes to court plans and things like that, because sometimes they can't. You're asking them to do things they literally cannot do without added support in place. And so it's not just about the person, right? You gotta have some knowledge of public transportation in the area where they are when you're thinking about reporting requirements. You gotta have some knowledge of the wait list at their local safety net mental health provider. You're telling them you need to get into therapy. Well, if the wait list is 3 months, they might not be able to for 3 months. And that's not their fault. And it's important that we are aware of that, right? And so in what we're trying to do to meet their needs, also thinking about promotion of things that are helpful. So pro-social activities, educational tools, mental health treatment, supervision, and then things that promote safety and security. And so when we're thinking about these plans, and this applies to youth and to adults, there are things that we need in order to be structurally competent, right? So you may have heard about this idea of cultural competency before, which is that you know something about cultures that are different from your own so that you can serve them and understand them better. Structural competence applies this to systems, right? So if I am covered by Blue Cross Blue Shield, I may think Medicaid works like Blue Cross Blue Shield unless I learn some things about Medicaid and how different the reality is of trying to get care with Medicaid versus Blue Cross Blue Shield. That is an example of structural competence. I make it a point to learn about how another system works, one that I may not have had, personal experience with. And that's going to be really critical when you're thinking about trauma-informed work, because you don't want to recreate those same structural traumas of telling people one thing and the system working in another way against them. So having knowledge of what's where and how easily it is accessed, you may be surprised if you were to call your local community clinic and see how long it takes for somebody to get an appointment or to see a psychiatrist in that clinic, right? That's important for you to know when you're trying to tell clients, what they should do or things like that. It also is important for you to know things about the reality of how that clinic functions. I'll pick on Georgia because that's where I am, but we have very low Medicaid reimbursement rates in Georgia. So what that practically means is that people will often try to make up for it with a volume model. So you see people very quickly. So if you haven't been in a public sector mental health system in the Southeast, I can tell you that by and large, they function kind of like this, right? So the initial appointment may or may not be with a physician, often isn't, and so you have to wait in order to get medication because somebody else has to see you first. That initial appointment, best case scenario, is an hour long. So in this hour, this clinician who is meeting this person for the very first time, this person who may have undiagnosed learning issues or language issues or intellectual disabilities or untreated mental illness, and in that hour appointment, they're trying to understand their current symptoms, their mental health history, their medical history, their substance use history, their trauma history, their family history, their educational history, their occupational history, their current social history, get a mental status exam, explain to them what is going on, make a diagnosis, and describe a treatment. A lot of these folks' trauma histories is going to take 40 minutes to do, right? So what happens is a diagnosis on the other end of that is incomplete, not comprehensive, and an experience for the client, right, where they know this is not going to help you understand all the things you need to understand about me. So that initial appointment, that 60-minute appointment, may be the longest anyone in that system ever has with them again, especially if you're talking about medication. So once you get to medication, what the psychiatrist or the nurse practitioner or the PA is saying in their note, what they are treating with medication is based on that first initial appointment. Follow-up appointments may be anywhere from 30 minutes, but even to as little as 15 minutes. So in 15 minutes, with someone with the complexity psychosocially that your clients have, someone is trying to assess how their symptoms are doing, their response to the medication, if they have questions to the medication, if they have side effects about the medication, any new changes in their lives in 15 to 30 minutes. So as you can imagine, sometimes that doesn't lend itself to people being able to talk about, this Haldol is really making it difficult for me to get out of bed without feeling dizzy. Right? And so you have situations that kind of set up the stage for people not taking medicine, not because they're bad people, but because they haven't had a chance to really talk to their doctor or their NP or their PA about what the medication is doing to them. So in that setting, right, when you have 15 minutes with somebody who may be medically and mentally and psychosocially very complex, what happens is that diagnosis that was made in that 60-minute session where they're supposed to go through all that stuff and determine what's going on with somebody, that diagnosis just gets carried forward. It's never reconsidered. It's not reevaluated. And so the trauma that was missed that very first time continues to be missed the next 2, 3, 4, 10 years that somebody is in a system. And the medications for bipolar and schizophrenia don't work because the problem is not bipolar or schizophrenia, it's PTSD. And then the client is blamed for not being medication adherent and not taking something that's not actually beneficial or helpful to them. And so that's an example, right, of the realities of how a structure works differently. When I use my private insurance, I don't have that same kind of experience. When you use your private insurance, you probably don't have that same kind of experience. So when you're coming up with these plans, making it a point to know about the county, the resources in the county that the client is from, right? And if you have counties that are overrepresented in your experiences or neighborhoods or zip codes, knowing about the schools there, knowing about the job opportunities there, knowing about the resource and the transportation there is going to be really important. When you create plans, questioning the degree to which it is system, responsible, adult, or child dependent, and also incorporation of what has worked before. What I often find is that people have had windows in their history where things went relatively well. So not just asking about, when did you take your medication consistently, but when did you do better in life? When were you functioning at a higher level, and what was in place to help you do that? Because for every person, that may look differently, right? But doing our best to recreate that for a person based on their own history. When we talk about risk factors and protective factors, it's all based on population level data. What that person is able to tell you about themselves is going to be the most relevant for that individual. And when you're doing this, right, placing an emphasis on what provides the best educational and occupational opportunities. And I will end with, which may have been predictable from a shrink, but I'll end with a plea for your own self-care and commitment to your own well-being. This work is really very hard. It is upstream in more ways than one, and we are people too, and we are on that continuum too. And what you find is that when it comes to trying to address inequities or traumas or bias or just hard things in general, how you are doing is going to impact that. And so it's really hard to come from an empathetic, culturally curious, structurally curious place if you feel defeated or beat down, if you are burned out, if you are having compassion fatigue. And so in order to do this work in a sustainable way, in order to do this work well, self-care is not optional. It is a necessary prerequisite to being able to provide trauma-informed service. I'll end with my self-care plan that I refuse to deviate from, which is that I sleep 7 hours a night, I work out 5 days a week, I visit my niece and nephew in Florida, who are the loves of my life, once a month, and I vacation every 3 months. Thank you all.